I'm Dr. Sid Kennedy, and I'm the Arthur Sommer Rotenberg Chair in Suicide and Depression Studies at St. Michael's Hospital and University of Toronto. The Arthur Sommer Rotenberg Chair was endowed in 1997 after the tragic death of a young physician, Arthur Sommer Rotenberg. And Arthur's mother, Doris Sommer Rotenberg, decided that she wanted to do something in Arthur's memory, and she was instrumental in raising funding for a university chair designed specifically to promote research into suicide studies and also to do anything to reduce the stigma associated with suicide. Well, I have been working in the field of depression particularly for several decades. I've been very interested in novel treatments. I've been very interested in identifying some of the variables that might help us to predict better outcomes for subgroups of patients within the field of depression and bipolar disorder. And I've always been struck by the fact that there are people within the community that we see with very severe treatment-resistant depression who are not likely to commit suicide, that whatever is different in their brain, in their life experiences, they feel hopeless, they often are in despair, but they do not have the makeup to attempt or successfully complete suicide. And yet there are other individuals, not everyone with the diagnosis of a major depression, probably 65% of people who die by suicide do have a depressive illness. But among those people, the depression circuitry may be different in suggesting that they have some different risks for the attempt or the completion of suicide. So I've always been very interested in trying to sort out some of the ways that we can better diagnose and match treatments to individual patients. So the prevalence of suicide in Canada overall is about 11 people per 100,000. Now, it peaks probably in the 45 to 55 age range, where it's about 16 people per 100,000. We also know that while women make more attempts, men actually complete suicide about 3 times more often. There are many myths associated with suicide, and one of the most common, certainly in the medical community, perhaps in non-psychiatrists particularly, is that it may be better not to ask about suicidal intent in case it gives a depressed person or a distressed person the idea. I think the evidence would certainly say that inquiring and opening the discussion is a lot more appropriate. There are other discussions around certain times of the year, people who are isolated and live alone, whether holidays like Christmas or other specific holidays might be associated more with suicide. These findings have not really been validated. I think the bigger question is, what are the ways that our society can help those who already have suicidal ideation, and that's the treatment level, but also what can we do perhaps earlier in the life of school children, young adolescents who are at risk in terms of suicide prevention. It does appear that people who make good, healthy attachments in childhood, whose bonding between mother and child is very strong and healthy, can cope with adversity in their own adult lives much better than people who begin life, unfortunately, with a very poor attachment, so they don't have a good sense of self when they face adversity, and they're more at risk of self-harm, suicidal attempts, and completed suicides. I think there's the larger question of how do we reduce stigma around mental illness in general, and perhaps suicide in particular. I think there's been progress, and I think Canada has actually been one of the leaders in dealing with stigma. I think when people who have been prominently recognized in the media die by suicide, it stimulates a public education, information surge, which unfortunately then settles down again. But I think that in general, I'll give you one example. In the UK, where people were concerned about the sale of acetaminophen, what we would call Tylenol, in drugstores in the UK, in large bottles, for example, 50 or 100 pills, the rate of liver damage and death was actually extremely high. So a public initiative to limit the number of pills that could be sold either in a drugstore or in a small, for example, convenience store to perhaps 20 or less did actually correlate with a reduction in this particular method of people either having a serious suicidal attempt or dying. Closer to home in Toronto, there's been considerable debate, for example, around the Bloor Viaduct, the question of whether closing that particular bridge over the Don Valley it resulted in people not being able to die by suicide at that place in the city. I think it would be naive to think that you can just close off bridges and all places where people can kill themselves, but I think that's a statement that our society takes measures to try and limit suicide. The other issue, for example, in Toronto has been the question of barriers on the subways platforms, whether you can actually reduce suicide. And again, I think while these can be helpful measures, they have to be set in the context of, for example, dealing with bullying in schools, things that actually increase people's risk before they ever find the particular place that they consider suicide.